This lecture is on oxygenation, and I tell you what, there's a million questions on the final off this PowerPoint. So study up, and a million questions on your current test. And the only reason I know that is I was just reviewing the final with a student who couldn't make it last spring, and he said, oh, now I remember it on that PowerPoint. So study now and study it again for the final. Remember that airways of the lung transfer oxygen from the atmosphere to that $1 million alveoli. At that most important alveoli, oxygen transfers to the blood, and carbon dioxide is removed from the blood. But that alveoli and that alveoli membrane, which is just a couple membranes thick, is so important for our whole oxygenation. Soon we'll talk about emphysema, and that all-important alveoli will be a key player. What I really want you to take away from this picture is that the superior vena cava, you know, all that deoxygenated blood, that's why it's blue, dumps into the right atrium. Inferior vena cava dumps it into the right atrium, and that's how we get the deoxygenated blood to the pulmonary artery to oxygenate it. Remember, with lung volume, there's two things you have to remember. Tidal volume, and that's the amount of air exhaled following a normal inspiration. So tidal volume is the amount of air exhaled following a normal inspiration. A lot of times they'll measure this when you're taking somebody off the respirator just to see what their tidal volume is and if it's adequate. Residual volume is the amount of air left in the alveoli after a full expiration. Again, residual volume plays a major factor or role in the destruction of those alveoli. So if the residual volume is huge, then it puts a lot of pressure on those alveoli, doesn't it? Work of breathing. Remember, inspiration is an active process. It's stimulated by the chemical receptors in the aorta, where expiration is a passive process that depends on the elastic recoil of the lungs. There's little or no muscle work with expiration in a normal patient. Now, surfactant is a chemical produced in the lung to maintain surface tension of the alveoli and keep them from collapsing. Now, when you have lung disease, a lot of times this surfactant production decreases or ceases, and then it's almost impossible to keep that alveoli from collapsing. What influences the capacity of the blood to carry oxygen? The amount of dissolved oxygen in the plasma, the amount of hemoglobin. Remember that hemoglobin is the major transportation of oxygen. Thus, anemia or inhalation of toxic substances decrease the oxygen carrying capacity. But remember that anemia is low hemoglobin, once a student didn't know that. And but remember that the hemoglobin carries the oxygen, and if you have anemia, you have less oxygen available. In carbon dioxide poisoning, hemoglobin binds to carbon dioxide, making to the carbon monoxide, making hemoglobin unavailable for the oxygen. So in carbon monoxide poisoning, hemoglobin binds with the carbon monoxide, making hemoglobin unavailable for O2. Factors affecting oxygenation. Sometimes you have a decreased oxygen carrying capacity. Sometimes you have hypovolemia, which is decreased circulating blood volume. It results in hypoxia to the tissues. The body tries to adapt by vasoconstriction when you have decreased volume. So in an attempt to maintain the blood pressure or blood to the major organs and brain, everything vasoconstricts and shifts the blood flow to the major organs and your periphery gets vasoconstricted, so it doesn't get as much oxygen to it. A decreased inspired oxygen concentration, decreased environmental oxygen. What was that mountain where everybody was dying this year? Was it Kilimanjaro? Where so many people, they couldn't move fast enough and they didn't have enough oxygen and everybody was dying. Tell me in class if I'm right, if it was Kilimanjaro. Anyway, back to our lecture. An increased metabolic rate increases your O2 consumption. This is huge, huge in a critically ill patient. What increases your metabolic rate? Temperature, right? So we always try to keep that temperature normal because it increases the metabolic rate, which increases your O2 consumption. Conditions affecting chest wall movement, pregnancy, your inspiratory efforts are decreased, or capacity decreased to the abdomen pushing upwards on the diaphragm, that little baby and all the everything pushing against the diaphragm. Obesity is a huge problem, like we talked about. You have decreased lung volumes, decreased tidal volumes, particularly when recumbent. Your abdominal organs push into your chest, making the diaphragm useless. So obesity is really a problem. The other thing with obesity is you have sleep apnea, don't you? Musculoskeletal abnormalities are kyphosis, lordosis, scoliosis. So different curvatures of the spine can affect your ability to breathe and your chest wall expansion. Trauma, when you had a fractured rib, none of the patients want to take a deep breath because it hurts so bad. I've never had a fractured rib, but they say it's such terrible pain, and none of them want to take a deep breath, and so they get pneumonia. Neuromuscular diseases decreased a patient's ability to expand and contract respiratory muscles, like at myasthenia gravis, Guillain-Barré, polio. Central nervous system alterations, trauma to that medulla oblongata, alters your respiratory movement. A transection, a spinal transection, anywhere from C3 and up, sometimes even down to C5 can result in respiratory paralysis. Breaks your heart. But anytime you have a high cervical spine transection, then it results in respiratory paralysis. Respiratory alterations in respiratory function, hypoventilation. As the alveoli ventilation decreases, the body retains CO2. So let's say when you have decreased respirations due to metabolic acidosis, or a lot of times right before someone codes, they have hypoventilation. But you can have COPD, overuse of morphine with the patient, decreases level of consciousness, and decreases your respiratory drive. So there's many things that cause hypoventilation. Hyperventilation can be caused by severe anxiety, infection, acid-base balance, excessive it causes an excessive decrease in CO2. Hypoxia, as we talk about so often, is inadequate tissue oxygenation, can be caused by apprehension. You'll first see restlessness. When a patient's O2 goes down, we'll look at that in a slide in a minute, you first see restlessness, inability to concentrate, and then a decreased level of consciousness. I'll tell you in class a story about this student and I in the long-term care and this patient who was hypoxic. So we said hypoxia is a low level of oxygen in the blood. You can measure it by a pulse oximeter or arterial blood gases. But what I want you to remember from this slide is that in a hypoxic patient, you'll see restlessness as the first sign of low oxygen. Cyanosis, or bluing of the skin and mucous membranes, are caused by desaturated hemoglobin. Cyanosis is a late sign of hypoxia. So highlight that, star it, circulate it, whatever you got, circle it, whatever you have to do. Remember that cyanosis is a late sign. If you wait to look at your patient when they're cyanotic, you're thinking to yourself, they're hypoxic, you've missed the boat. Circummoral cyanosis is that O2 around the mouth, circummoral cyanosis. Then you have central cyanosis, which is you even get bluing of the tongue inside there. And then you have nail bed cyanosis, all from desaturated hemoglobin. Now, this is huge. Remember this from this day forward. If you walk in a room and a patient has trouble breathing, we call that dyspnea, right away before you do anything else, elevate the head of the bed. It takes the organs off the diaphragm and helps them breathe easier. Then, if you feel you need to have to put oxygen on, go ahead and put oxygen on. And if you hear gurgling in the back of their throat, you have to suction that, don't you? Or that oxygen isn't going to get by that mucus plug. So, just to reiterate, hypoxemia, a lot of times, some people will say it's decreased blood decreased oxygen in the blood, hypoxia, inadequate tissue oxygenation at the cellular level. But I'll tell you what, in the hospital or anywhere else, we just say hypoxia, and it's inadequate tissue oxygenation at the cellular level. Hypercarbia, high carbon dioxide, hypocarbia, low carbon dioxide. Dyspnea assessment. Remember these terms, memorize these terms. So dyspnea, when we're assessing somebody who's having trouble breathing, they can have paroxysmal nocturnal dyspnea, sudden awakening caused by shortness of breath during sleep. The patient feels panic, inability, and so it's a frightening thing. So it's in the middle of your sleep and you have a sudden awakening. Conversational dyspnea is when you have the inability to speak complete sentences without stopping to breathe. Orthopnea, sometimes people get orthopnea and paroxysmal nocturnal dyspnea mixed up, but orthopnea is difficulty breathing when laying down. So difficulty breathing when laying down. Stridor is a high-pitched, harsh crowing sound from a partial obstruction of the larynx, and it is scary. And I'll tell you a story about that in class. But wheezing, then, is from a constricted bronchus or a bronchus filled with mucus. Can be from asthma, chronic bronchitis, but you hear they describe it as this musical sound that goes through the lungs. How do we measure O2? You can either measure O2 saturation or arterial blood gases. O2 saturation gives you the amount of estimate of the amount of oxygen on that hemoglobin molecule, where arterial blood gases give you the pH, exact PO2, PCO2, and bicarbonate. Now, in the intensive care unit, we get arterial blood gases all the time. You can't, in the ICU, when you get there in your second semester, you might spend a day in the ICU, you'll see that they have lines in the radial artery so that we don't have to keep sticking these people. But remember, that's the difference between O2 sat and an arterial blood gas. Oops. The pulse oximeter, did I skip that? Sorry. The pulse oximeter is non-invasive. It's the greatest thing that's happened to nursing as far as figuring out the oxygen level. It reflects the percentage of hemoglobin molecules carrying oxygen. Normal is 95 to 100%. Usually we don't worry until less than 90%. Now COPD patients might have their own normal. They might have 86% as their normal O2 sat. So you always have to know your patient's baseline. So it's another thing you got to remember. What gives you an erroneous O2 sat reading? So that O2 sat, where'd it go? Sorry. Okay, this O2 sat right here. The top is emitting light, and the sensor down here is estimating the oxygen. So there's light going through your finger. The sensor at the bottom is estimating how much blood is, or how much oxygen is affixed to that hemoglobin. Now you get erroneous readings, sometimes with interference with light transmission, such as when you have anemia. I want you to remember this, if there's nothing else you remember. Anemia, or low hemoglobin, low red blood cells, causes a false reading because when you put that little catheter on, or little machine on the tip of your finger, it reads that 100%, let's say, of the oxygen affixed to that hemoglobin because there's such few hemoglobin molecules. So it gives you an erroneous reading. It makes the machine think that your O2 is really high because all of it binds with that hemoglobin, but really in effect you have not low hemoglobin. Let's see what my little puppies do. If you have elevated carbon monoxide levels, so if you have carbon monoxide poisoning, you'll get an erroneous O2 sat reading. If you have black or brown nail polish, you'll get an erroneous O2 sat reading. If you have jaundice or a lot of bilirubin in your blood, you'll get an erroneous O2 sat reading. And sometimes really dark skin pigmented people, you have trouble with getting O2 sat. The other thing, okay, so the last problems were all light transmission. Now let's talk about problems with arterial pulsations. When you have hypotension, kind of talked about this, the body shifts all the blood to your major organs to try to oxygenate those major organs. So what does that do for us? It causes vasoconstriction in our fingers and distal digits, right? So we get an erroneous reading. If we're hypothermic, let's see how long this lasts. If we are hypothermic and your blood and your temperature is low, then, so back to hypothermia, when your temperature is low, you also have vasoconstriction. So not as much blood is getting to the distal finger, right? Distal port of your hand or fingers. If you have atherosclerosis or plaque buildup in your vessels, then that gives you an erroneous reading. Low cardiac output, such as in shock, or if you have bad left-sided heart failure, you can have erroneous readings because, again, it's shifting blood to the major organs and not to the periphery. So if you have any question, let's talk about that in class. Arterial blood gases, remember, I love them, love them, love them, because it gives you an exact PO2. It's not an estimate, it's an exact. It also gives you PCO2 readings, pH, bicarb, so it's fabulous. But it is invasive. It can cause infections. It can cause sclerosis of that artery. What does that mean? Well, from all the repeated sticks, you get this scar tissue, and you can actually cut circulation off to that radial artery. But luckily, the ulnar artery works, so you don't lose your hand. But they are very painful. If they are done wrong, They are very painful. That was my job and the med student's job at Creighton. We went through everybody in the hospital and had to draw all their arterial blood gases. And my med students got really good at it. Now, the new thing now is COPD, right, or chronic obstructive lung disease. We used to make this distinction between emphysema and chronic bronchitis, but now we lump it together and call it chronic obstructive lung disease or chronic obstructive pulmonary disease. When we think of emphysema, and both of them are usually 95% of the time from cigarette smoking. Hold on, let me move my papers. 95% of the time from cigarette smoking. You have chronic inflammation of the various parts of your lung tree. So with that smoke, it damages the alveoli membrane, that $1 million alveoli. So remember, emphysema, the whole problem is you have destruction out of the alveoli, so there's not enough membrane in there anymore to diffuse oxygen and take away carbon dioxide. So, and then chronic bronchitis, here you see, here's your and my normal bronchus. And then you have chronic bronchitis from chronic inflammation, then you get that inflammation to go down with antibiotics, then inflammation again, so this repeated swelling, and the swelling goes down to the bronchus. So then you start to develop this hypertrophied tissue, and it turns into chronic bronchitis. So we said we lumped them all together, chronic bronchitis and emphysema. Now, with COPD, they have to force exhalation. So all this little trapped PCO2 in here, they have to forcefully exhale. When we talked about residual air volume earlier, now all this residual air volume in the alveoli causes alveoli membrane destruction. That's why patients with COPD have pursed-lipped breathing, they call it. Pursed-lip breathing. I don't know why they call it pursed-lip breathing. But it's exhalation through the mouth with lips pursed to cause slow exhalation and more effective exhalation. So pursed-lip breathing. Barrel chest. A normal chest, you and I, you see this transverse diameter, we're 1:2 ratio. This is the anterior, here's your posterior view, so we have a 1:2 ratio. Now, a COPD patient has a 1:1 ratio between your posterior and your anterior parts of your chest. This is the transverse diameter. So, remember the word barrel chest. How do they get this barrel chest? It's from their forced exhalation and from their accessory muscles between their ribs working so hard to breathe, so hard to exhale the PCO2 that their chest becomes hypertrophied. And that's barrel chest, and that's classic of COPD. Now, you have to know this orthopnic position. Many patients breathe easier leaning over a table. They put pillows on the table and they lean over the table, and this opens up the rib cage and helps them breathe easier. So this is called the orthopnic position. This is exciting to learn about or understand, maybe you know it all, but to understand and talk about it again, because you'll take care of a lot of patients with pneumonia. Now remember that pneumonia is infection of the lung tissue itself. So that tissue becomes infected. You hear crackles, rhonchi, slight wheezing. We're going to talk about that in our respiratory assessment lecture. It can be from aspiration. What is aspiration? When you get either mucus or food or vomit down your trachea, and down into your right and left main stem. It is so irritating to that lung tissue. It sets up a pneumonia, and those patients get really sick. Look at that, the right bronchus. I guess it doesn't show it very well on this picture, but just know that the right bronchus is shorter than the left. It's wider and it's more vertical. So a lot of times if you aspirate or get food down, vomit down your trachea and into your lungs, it a lot of times will affect the right lung before it affects the left lung because of that shorter bronchus. As we said, aspiration pneumonia results from inhalation of fluid or foreign matter into the lungs and bronchi. To prevent aspiration, we elevate the head at least 30 degrees. And if the patient starts vomiting, we turn them on their side. So we always turn a patient on their side when they start vomiting. Atelectasis then is something totally different. It's collapse of the alveoli. Thank you for putting up with my puppy. Atelectasis is collapse of the alveoli. You have absent breath, sounds nothing's moving through there, right? So you have collapse of that alveoli. And a lot of times it'll be from bed rest, they don't breathe as deep, and from post-surgical. So let's stop here